We are here for our scientific session, number 5, with a distinguished moderator. I am very pleased to introduce Dr. Antonia Stephen as our final distinguished moderator of the meeting. She obtained her medical degree from Harvard Medical School and completed her general surgery training at Massachusetts General Hospital. She then went on to be the first Cleveland Clinic fellow, is that correct? Second Cleveland Clinic Endocrine Surgery Fellow. She then returned to Harvard Medical School and Mass General Hospital, where she has had an endocrine surgery practice. She now serves as an associate professor of surgery. She's the director of the Mass General Brigham Combined Endocrine Surgery Fellowship and is the section chief for endocrine surgery there. The theme of our meeting this year is strengthening our connections, and no one embodies that theme in every facet more than Apple. To tell you just how strong her connections are with her mentors, she actually lived on Dr. Siberstein's property while she was a fellow there. And there may or may not have been a story about how she would hear the garage door open when he would leave for work in the morning and realize she had to get going because her boss couldn't get there before her. One way that she embodied in me, or taught me, to strengthen connections was first with my patients. She always expressed the importance of taking time and listen and genuinely caring. She also strengthens connections with her referring providers, with her multidisciplinary collaborators, with her colleagues and the OR team. Every member of her team is valued and appreciated. I distinctly remember being in her clinic and having her see patients with me, and then the patients would leave and she would pull out her phone and call the referring physician right away with a report and a plan, and the conversation wasn't just about the patient. It was about them and their lives and their families, and it was something that really struck me as one of the most important things about being a physician on a team. She brings this to her trainees and mentees, for whom she imparts wisdom, practice tips, honesty, and candidly describes her challenges and how she's overcome them. She's strengthened her connections as a strong family member, a mother of 3 successful, happy, and supported young adults. And most impactfully, she showed me how to strengthen a connection with myself. Apple has long defined her own version of success. She's eschewed the traditional checklist methods of achieving publications and service responsibilities, though she does have many of those. She challenged me to discover what brought me joy and satisfaction, and then to go all in, even if it means you have to schedule slightly fewer cases so that you can make it to SoulCycle before the 4 o'clock deadline. She encourages all of us to forge our own path with self-efficacy and self-compassion, and I'm so grateful to have learned from her and consider her a colleague and friend. Dr. Stephen.
So, a huge thank you to Abby, to Rachel, to AAES leadership for this opportunity to speak and moderate today. So, my first reaction when I received the invitation and read the instructions for this talk was, what could I possibly teach this absurdly experienced group of world experts in endocrine surgery? I mean, we all basically do the same 3 operations, and I don't do adrenal surgery, so I'm now down to 2. What sets me apart? What do I know that they don't know or do that they don't do? And I racked my brain. Should I talk about how I make really small incisions or why I don't use intraoperative PTH anymore? But as these ideas popped up, I kept thinking they probably already do this and do it really well. And besides, everything I thought of sounded kind of boring, especially for an afternoon talk. So I did what I always do when I feel stuck and I need advice. I called Saray. Saray told me to call Matt Nays, who did this last year, and Rachel Kells, and I called them, and they were busy. They said they would call me later, which they did. But in the meantime, as I sat with this question, I reframed it. And I asked myself, what have I, in the shared context of being an academic endocrine surgeon, truly invested my time, energy, and effort into. And it was with this reflection that I was able to identify what I could meaningfully share with you here today. So in my career as an academic endocrine surgeon, I've focused on a lot of things, but three main things listed here in chronological order. Number one, building a busy, efficient, and patient-centered endocrine surgery practice. Leapfrogging ahead to more recently, I had the privilege of being asked to serve as the MGB endocrine section chief with the responsibility of merging two previously separate academic surgical programs. And in between, in 2020, I was asked by Dr. Richard Hoden, my division chief, and Dr. Keith Lillimo, our department chair at the time, to serve as the Director of Wellness for the Department of Surgery at MGH, a position that had not previously existed. And I'm deeply grateful to both of them for that opportunity, and I really hope that Dr. Hoden is here right now to hear me say that. So because this role had not previously existed, it was not very well defined, and I thought to myself, how cool. When I'm not doing surgery, I get to do all sorts of fun stuff like plan SoulCycle rides, get some sweet green salads into the surgeon's lounge, and we did that, but I soon learned that the role entailed much more. And we did a lot of different things in our wellness program, centered around personal resilience, with lifestyle instruction, health and nutrition, work-life balance, and as Saray spoke so eloquently about yesterday afternoon, community building. But the aspect of the role that interested me the most was how to use coaching and organizational systems to maximize your productivity while preserving your mental, physical, and emotional well-being. And I soon realized that while I used to sort of see my roles or my job like these or like this, that I really couldn't do either of these things, at least not very well, without an intentional, sustained, and ongoing effort with this one. So how do you do this? How do you maintain your energy, improve your productivity, and bring your real full firepower to all the things that you want to do? Do you talk to an executive coach? Do you download a calendar app? Do you hire more APPs? Do you listen to an awesome podcast on organizational psychology? Well, you might do all of those things, or maybe some of them, or maybe none of them, and maybe different things. I'd like to share with you some practical tips for this, but before I do, I would like to share two truths about it. Truth number one size never fits all. There are many different ways to be productive, and no one system, app, framework, or strategy is going to work for everyone. Productivity is personal. It depends on how you think, how you work, how your brains work, and what your environment is demanding of you. Truth number two, productivity is not a fixed skill, even for one individual person. Your roles change, the demands on you change, your energy changes, and your systems have to adapt accordingly. So for the next 5 minutes, I'd like to share 5 tips about this, and I swear Sheree and I did not coordinate on the 5-tip thing. We just have telepathy from having worked together for about 18 years. So tip number 1, oh, I'm sorry, and the real question here is not what's the best system, but what works for you right now, and how do you put it in place and stay engaged in continually refining it. So tip number 1, spend intentional time reflecting not just when and how to execute a task, but on why you are doing it. In this equation, the why is the vision, and the when and how is the execution. You've probably heard the term an open loop. An open loop is anything you're engaged in, a research project, a book chapter, integrating 2 academic surgical programs. People with good vision open loops, and those with good execution close them. To be productive, you need both. Practical tip. The next time you're asked to do something or given an opportunity to apply for a leadership position, to submit your materials for academic promotion, before you make your to-do list, before you send an email, before you fire up your CV, spend a little time reflecting on why you want to do it. Tip number 2, when you feel like you need more help and support, and we always do, take careful inventory of your current resources and support systems and make good use of them. Concrete example, before you hire an APP or consider hiring an RN, make sure you're getting your best work out of your administrative assistant or your medical assistant. And if you're not, you might need to spend some upfront time getting them up to speed. If you want advice on this, Dr. Rashri Gartland, my close friend and colleague, is an absolute master at instructing, informing, and therefore bringing the best work out of her administrative staff. Rashri, I've been watching you very carefully. Tip number 3, related to the last tip, spend more time up front setting up systems and less time putting out fires. Concrete example of this, instead of correcting that epic template in your note, time after time, patient after patient, week after week, spend an afternoon or maybe even a day updating your templates, updating your order sets, getting an Epic at the elbow person with you, or even better, spending some time with an Epic savvy colleague. Or, as Dr. Hashimoto talked about, learn about the AI systems that could help you with that. Once again, more time up front, lots of saved time and energy for later. Tip number 4, engage in developing systems for list and calendar management instead of allowing to-do lists and tasks to take up space in your brain. Your brain is not a storage container and should not be used like that. It's a creative vessel. And remember, lists are not a one-time thing. They're a living, breathing system, and your list system and your calendar are the backbone of productivity, so make sure they're working well. Concrete example, my latest read, which I'm halfway through, is a book called Uptime, which is written by the executive head of productivity for Google, where she describes an adaptable and usable system for calendar and task management. This is my 3rd such system in the last 5 years. And finally, find the joy in whatever you do. Everyone who knows me knows I have lots of fun in the operating room, and I'm sure you all do as well. You certainly do not need instructions from me on how to do this, but we all need reminders. So if you have a minute, check out this short commentary article in the New England Journal of Medicine about how bringing the fun into surgery balances out all of the other high-stakes things we do every day. So I think it's time to get to the scientific program. Thank you so much for your attention, and I hope this was helpful.
Good afternoon, everyone. Hope the mic's on. Yeah, it sounds like it is now. The first paper for presentation is the effect of hospital profit status on outcomes and cost for endocrine surgery, a state-based analysis. This will be presented by Dr. Shafiq from the University of Pennsylvania.
Thank you so much. Good afternoon. I am Neha Shafiq, a surgery resident at University of Pennsylvania. Thank you to AAES for the opportunity to present our work today. We have no conflicts of interest or disclosures. Over the last 2 decades, the United States healthcare system has undergone rapid consolidation and increasing corporatization. There has been a greater than 50% increase in the proportion of investor-owned or for-profit hospitals since 2004. And now nearly 40% of Medicare-enrolled hospitals are classified as for-profit, with the remainder as not-for-profit or government-owned. These changes have raised questions of how hospital financial structure and its subsequent incentives may impact the quality of care. For-profit institutions with an explicit motive to return profit to stakeholders have been reported to improve their margins by a variety of mechanisms. The impact of these efforts on quality of care has been really heterogeneous in prior literature, with some work suggesting that morbidity and mortality are not affected following for-profit conversion, and others demonstrating an association between for-profit status and greater complications, readmissions, or patient and provider dissatisfaction. However, most of this prior work on hospital financial structure and outcomes has focused on acute medical conditions, or things like emergency general surgery. Endocrine surgery, on the other hand, is largely comprised of elective procedures, allowing for patient preferences and market forces to factor into hospital selection. Endocrine operations are also frequently outpatient or short-stay procedures, where short postoperative episodes create direct pressure on efficiency metrics. Endocrine surgeons also are rapidly adopting new technologies and approaches such as robotics, which makes it an appealing service line to focus on following for-profit acquisition. We therefore aim to study the association between hospital profit status and clinical and financial outcomes of endocrine surgery as a representative of elective surgical care. To do this, we performed a retrospective cohort study using HCUP data of the states listed on the slide. These states were selected as they permit tracking of patients over multiple admissions and have both for-profit and not-for-profit hospitals. We identified adult patients who underwent thyroidectomy, parathyroidectomy, and adrenalectomy, and our primary exposure was hospital ownership status, which we obtained by linking HCUP hospital identifiers to the American Hospital Association annual survey. Our primary outcomes were costs, both total costs and costs per day, length of stay, and 30-day readmission rates, which we defined as any urgent or emergent readmission occurring within 30 days of the index encounter. After applying all exclusion criteria listed on the slide, a little over 89,000 encounters were included, with 14.1% of these occurring at for-profit hospitals. Of these, 62% were thyroidectomies, 38% parathyroidectomies, and nearly 4% adrenalectomies. These are some of the demographic characteristics of our cohort, which was 77% female and a median age of 58 years. Compared to nonprofit hospitals, for-profit hospitals cared for a greater proportion of Hispanic patients, those with multimorbidity, and those in the lowest income quartile. After multivariable adjustment, treatment at a for-profit hospital was associated with a modestly shorter length of stay at 2 hours and lower costs of around $650. When controlling for length of stay, for-profit ownership continued to be associated with lower costs. And despite these cost reductions, there was no evidence of a difference in 30-day unplanned readmission. These findings differed in subgroup analyses by type of surgery. While findings in thyroidectomies and parathyroidectomies largely mirrored those of the total endocrine surgery cohort, for patients undergoing adrenalectomy, there was no difference in costs or length of stay between for-profit and not-for-profit hospitals. While some of this variation from the overall cohort could be attributed to the smaller sample size of adrenalectomies, it could also provide some insight into the mechanisms underlying the cost efficiency seen at for-profit hospitals. While they may have optimized costs for outpatient ambulatory surgery, they may be unable to do so when it comes to less frequently performed surgeries or those requiring more resource-intensive perioperative care. Our findings should be interpreted in light of several limitations. Firstly, this is an observational retrospective study with all the limitations therein to this type of work. Secondly, we are missing important clinical outcomes such as post-discharge ED visits that do not result in a readmission or those specific to endocrine surgery such as hypocalcemia following neck surgery. And thirdly, the data from these 4 states may not be generalizable across the United States health market. Despite these limitations, this work represents the first description of hospital ownership, which is a rapidly evolving feature of the healthcare landscape on endocrine surgery in a large multi-state cohort. We find that for-profit and not-for-profit hospitals serve different patient populations. Despite this difference, for-profit hospitals are able to achieve equivalent or improved outcomes with lower costs. This improved efficiency is mostly seen in outpatient or less resource-intensive surgery, And together, this work suggests that for-profit institutions may have found mechanisms to optimize overhead without compromising in quality of care. And future work is needed to ascertain which factors are leading to this improved efficiency and whether they can and should be broadly applied across both service lines and hospitals with different financial structures. Thank you, and I'll take any questions.
First question on the right, please.
Hi, Tony Bedonato, Rutgers University. Thank you for this great study. Were you able to look at factors that have been previously published as resulting in these similar outcomes as to what you found in your study? Namely, high volume surgeons have shorter length of stay, readmissions, et cetera. Complex patients or patients from underserved areas are more likely to have worse outcomes in these things. So how do you reconcile all of those things with your findings from this data set?
Absolutely. Thank you for that question. So we did adjust for volume, and I can maybe go back to show you. So we defined high volume hospitals using actually individual surgeon thresholds. So we did that for adrenalectomies as greater than 6 adrenalectomies, thyroids and parathyroids at 50 of each surgeries each, and then high volume for the entire cohort as greater than or equal to 106. And we adjusted for that in our multivariable model. And then your second question in terms of complexity of the patient, we did adjust for both multimorbidity, which is defined as a combination of already qualifying comorbid sets that have shown to increase to a doubling of risk in surgical populations in previously published literature, along with sociodemographic variables such as the income quartile and insurance rates that they were that the patient was in at the time of the encounter. So the results that I showed you are all results of the multivariable adjustment, all adjusting for those variables.
Thank you.
Sam Inuma, University of Rochester. Thanks so much, Neha, for that talk. My question is just on the number of hospitals that were included and whether or not you think that it represents what's happening nationally. From what I can understand and read the abstract, there are about 100 in the for-profit group and 200 in the other. So out of those 300 hospitals, that's in the larger scheme of maybe 4,600 hospitals, we're maybe looking at a very small subset. So do you think it is representative? And if it is or isn't, is there other work that you guys can do to try to evaluate that? I know those databases cost a lot of money per state, so that's a challenge.
Yeah, absolutely. We've been focusing on these 4 states in particular in our group just because they do allow for tracking over multiple readmissions. And I think that because of the market forces in those states have seems to be what a roughly equal proportion of for-profit and not-for-profit hospitals, it allows us to analyze what that market forces are doing and how patients are selecting those hospitals. So there were a total of 312 hospitals that were included in our cohort. 8 actually changed profit status during our study period. So we did perform a subset analysis of that, of hospitals that retained their profit status during that study period as well, and we found similar results. I think that we're seeing a real rise in prevalence of these for-profit institutions across states, and it'll be very interesting to see the development of these and how they impact outcomes nationwide.
Thank you.
I think that's all we have time for questions now. We can move on to the next.
Thank you.
So our next paper is from the Cleveland Clinic, and that was a true story about Alan's garage, by the way, and he did beat me every single day. The impact of a cost reduction initiative among high-volume endocrine surgeons in a large health system, presented by Dr. Eduardo Canalizo.
Thank you. Thank you for the opportunity to present our work. These are our disclosures. Hospital economics are strained by rising salaries and labor costs, supply chain pressures and reimbursements that no longer keep pace with expenses. This has created a challenging financial landscape across the country. In fact, 4 in 10 hospitals lost money in 2025. While physicians may feel insulated from this, the consequences are far-reaching, affecting staffing, resources, and ultimately the sustainability of our practices. Supply costs rising 8.2% annually are key drivers. Surgeons cannot control insurance reimbursements or nurses' salaries, but they can actually reduce OR spending. The aim of our study was to look at a program to reduce supply expenditure. So we implemented a cost reduction initiative in the operating room at the beginning of 2025 within our endocrine surgery department. First, we gave individualized feedback on supply costs, where surgeons were shown exactly what every item costs. Second, not opening disposable items until they're actually needed, coordinated with our nursing staff. And third, seeking out vendor alternatives and contracting for lower cost options where possible. So we reviewed the financial data for more than 2,700 thyroid and parathyroid surgeries performed within our department. And 2024 served as our pre-intervention year and 2025 as our post-intervention year. 62% of the total cost of the surgical encounter is actually realized in the operating room. Of that 62%, 69% is attributable to supplies, items directly under the surgeon's discretion, such as every single pretty much supply, while the remaining 31% is a time-based calculation primarily based on non-physician staff salaries. When we actually multiply these percentages, it gives us approximately 42% of the entire hospitalization costs driven by OR supply costs alone. This makes it a high-impact, actionable target. Here, the y-axis reflects the average cost per case normalized to the overall supply cost across both years to preserve contracting confidentiality. The x-axis shows the percentage of the case where the item was used, and the size of the bubble represents the cost of what the item was at the time it was used. So generic supplies such as gloves, gowns, drapes, sutures, and manual clips, and other disposable items are used in 100% of the cases. Through limiting the opening of non-essential items and seeking cheaper alternatives, we achieved a 27% decrease in cost. The most dramatic change in our group wasn't actually in vessel sealing devices. By combining contracting alternatives with restricted use in parathyroid procedures, we achieved a 74% reduction in cost. The use of hemostatic agents was also actively discouraged, and through that we achieved a 42% reduction in cost. And for nerve monitoring, utilization was actually higher, most likely due to case mix, but contracting cost reduced by 4%. And finally, automatic clip pliers. Utilization decreased overall, but an important finding here is that actually these were tended to be higher cost. So this actually represents an opportunity for further cost improvement. Taking all together, across our entire endocrine surgery department, this translated to a 41% decrease in supply costs. We then asked whether this reduction was consistent across all procedure types or was driven by only one specific operation. So parathyroidectomy had a 51% decrease in supply costs. Lobectomy had a higher baseline cost at a 43% cost decrease. And lobectomy had a higher baseline cost, a 41% decrease. And even our most complex procedures, defined as neck dissection, completion surgeries, and combined resections, had a 35% decrease. Now, what does a 41% reduction in supply costs actually mean for the total hospital bill? For our endocrine surgery intervention group, that translated to a 17% decrease in reduction in total direct costs. And we then compared this to two control groups within our health system: high volume general and ENT surgeons and low volume surgeons, neither of whom participated in this initiative. Both high volume and low volume groups saw a 9% cost increase, which was driven predominantly by a rise in supply costs. In summary, OR supply costs are a major modifiable driver of hospitalization costs and a high impact target for reduction. A multimodal intervention significantly reduced supply costs by 41% and a total by 17%, while non-intervention groups saw an increase. And other opportunities remain, such as reducing individual surgeon variability and improving OR time efficiency. Thank you, and I'm happy to take any questions.
Eduardo, thank you for that wonderful talk. Very interesting. I use all of those things, so. Cord.
Cord Sturgeon, Chicago, no disclosures. Thank you very much for that interesting topic. It's right up my alley. I think about it every day. Couple quick questions. How did you get your cost? Was it from Epic cost receipt, or was it from WaveMark or something like that? How'd you do it?
So we actually have across our institution, we have a platform called Tableau.
Tableau.
It actually pulls out every single charge in our organization.
Perfect. Yeah. So this is from the perspective of hospital cost. It's very important to clarify. And so therefore, are you planning to look at margin contribution amongst the providers that participated in this to see what it did?
Yeah, exactly. That's actually a very good observation, and that's definitely the second part of the project. Yes.
Great. I think you should. Thanks.
Yeah.
Amanda Laird, New Brunswick, New Jersey. Much like Dr. Sturgeon, this is also one of my favorite subjects. And the more cynical part of me thinks a little bit about how you present this in the discussion, right? Because we all operate within a set of finite resources. And I think about these things a lot because I look at this as where do we gain opportunity to get back to ourselves as healthcare providers? Because as years have gone on, and I've been in practice for 21 years, the administration takes more and more and more and more and more of the pieces of the puzzle.
Yeah.
So how are you able to present these data in a way that says, okay, we're doing our part, so where is the opportunity that we get back? And I think that margin is certainly an important part of that.
It's a very good question.
I apologize, it may be more philosophical.
A little bit, a little bit. I think that goes back to the little cartoon that I put in first. I think we're all in the same boat. In at least this is what we can do, and in terms of administration, I really don't know. But that's a very good remark. Thank you.
Next question.
Yeah, Matt Nays, Boston. My disclosure is that I have 5 kids. And when we go to Costco, they always want to buy every candy and toy and everything because they're not price sensitive. They just want those things. And so it's like surgeons, in a way, have to be stewards of this, but we don't know what the prices are of anything. I want to use VistaSeal and ligature and all of these things, but I don't really know what the costs are. So my question for you is, how do you relay that information to the surgeon so that we can actually say, wow, I didn't know a ligature costs $400 or whatever it costs. So maybe we can feel a little bit of that in a way that makes it more meaningful for us to preserve costs.
Yeah, absolutely. Thank you. Thank you very much for your question. So I think that goes back to our first intervention, the feedback. We went through 123 items that go into an operating room, and we were actually shocked about what the costs were. For example, for some automatic pliers, the price of a vessel sealing device versus a reprocessed one, et cetera. So actually, I would just encourage all of you to just go back to your home institutions, go through every single item, and just realize how much everything costs, and speak and choose whether you can just have a cost reduction.
I think we can take one more question. Oh, Peter, or maybe two more.
President.
Okay, President.
Past president.
As long as Saray isn't going to tell me I can't have my ligature anymore.
I'm thinking of that. I guess I wanted to follow up on part of your study about, first of all, did your cost reduction in supply result in any increase in time in the OR? That was one question. And the second question, I noticed you only maintained 1 year. Was it sustainable?
Yes. So the first question, we actually did take a look at time, and that's actually one of the main differences between our group and the other high volume, low volume groups. Well, we really don't want to make time as one of the targets of cost reduction, because that would take patient safety into consideration. But what you can actually do in terms of time is actually reduce the non-procedure time within the OR. For example, at the clinic, we have we're very lucky to have a really good team of nurses and anesthesia team. So when the patient comes into the room, and from that time till we do the incision, it's literally 7 to 10 minutes. It's really, really, really fast. The same thing from the skin closure till the patient is out of the room. To answer specifically your question, we did not see any increase in times within our group and in the other two groups. And the second question was? Oh, the sustainability. So so far, we've maintained every single cost reduction that we have had has been maintained, and this is until just 2025. So we're pretty sure that this is going to continue to be sustainable. Thank you.
Great, thank you so much.
Our next paper for presentation is Before the Incision, How Thyroid Surgeons Foster Patient Trust Preoperatively. This will be presented by Sarah Lund from the University of Michigan. Thank you.
Good afternoon, and thank you for the opportunity to present. These are our disclosures and our funding sources. As a surgeon, establishing trust with patient is not only the bedrock of a successful patient-surgeon relationship, but it is also an important mediator of clinical outcomes, such as quality of life. While establishing trust is essential, it is not clear how surgeons develop these complex skills, as studies indicate that trust building is not effectively taught during surgical training. To effectively teach residents how to establish these complex skills, we must first better understand the discrete behaviors that surgeons use to establish trust with their patients. Therefore, we aimed to identify trust-building behaviors that surgical attendings use during preoperative counseling of patients referred for thyroidectomy, and to identify the trust-building behaviors that surgical trainees used in the same setting. To achieve these aims, we conducted a secondary analysis of recorded patient care visits of patients referred for thyroidectomy who were previously recruited to participate in a study of decision-making in low-risk thyroid cancer. We had access to transcripts of recorded visits between patients, their surgical attendings, and surgical trainees across 3 academic medical centers, and transcripts from these visits were reviewed by one coder who inductively developed a preliminary codebook. This codebook was reviewed and finalized by all study team members before 2 coders divided and coded all transcripts. Codes were then integrated into themes looking into the discrete trust-building behaviors that both attendings and trainees used with their patients. Transcripts from 44 patients seen by 14 surgeons or surgical attendings and 14 surgical trainees were analyzed. 8 themes emerged from 24 discrete trust-building behaviors, six of which described attending behaviors and 2 of which described trainee behaviors. We noted that surgical attendings use bidirectional communication when establishing trust with their patients. There were several discrete behaviors we noticed, such as eliciting a patient's story, active listening, checking baseline knowledge, avoiding repetition of what the trainee had previously discussed, and providing space for patient questions. Surgeons also built personal connections with their patients to establish trust, asking about a patient's personal lives, using humor to put patients at ease, making it clear that the surgeon had spent the time to look that patient up before the visit, reassuring patients when they had concerns, surgeons humanizing themselves during the visit, and vocalizing concern for a patient's physical comfort during the visit. Surgeons also demonstrated expertise to build trust by highlighting their previous experience with similar patients, referencing the literature, citing personal complication risks, and using teaching strategies, such as metaphors or visual aids, to ensure their patients understood. Surgeons would acknowledge uncertainty to build trust, through behaviors like admitting that their diagnosis could be wrong in certain circumstances, and admitting when a surgeon simply could not know something about a patient's care. Respecting patient agency was another way in which surgeons established trust, through behaviors like allowing patients to change their mind during the process, not pushing patients into surgery, and being willing to alter the plan to better fit a patient's wishes or circumstances. Finally, surgeons would streamline logistics for their patients to help establish trust through things like communicating with other team members on that patient's behalf, answering straightforward non-thyroid medical questions, as well as making the preoperative care process easier through coordination efforts. With respect to trainee behaviors, we noted that trainees modeled attending trust-building behaviors predominantly, with one addition. Trainees would defer to their attending's expertise during their visit to help lay the groundwork for attending patient trust. When trainees modeled that behavior, they predominantly relied on bidirectional communication and establishing a personal connection with their patients instead of the other behaviors we noticed. In conclusion, we identified several discrete trust-building behaviors that surgical attendings use when in preoperative counseling with patients, informing a proposed model for teaching trust-building to trainees. When trainees used these behaviors, and while they used some of them, they typically did not use more advanced behaviors, such as demonstrating expertise, acknowledging uncertainty, respecting patient agency, or streamlining the care process. These findings support the creation of a training communication course for surgical residents focused on these more advanced trust-building behaviors. With that, I'd be happy to take any questions you may have.
Thank you, very nicely presented. I'd like to start off with a question myself. Did you consider video? I know this was like kind of a retrospective data, but did you consider videotaping? Because I think body language is incredibly important. There's other nonverbal forms of communication.
Definitely. It's a very important question. We focused solely on spoken language in this study because it was a retrospective analysis looking at recordings we previously had from another study. I think that is something that I would want to do before actually developing this curriculum, because I think a spoken line can differ widely based on the nonverbals that you give in a room. And so while this study really defines kind of the verbal communication patterns that can help you to establish trust, an additional study looking into what those nonverbals may be, so that way you can pair those together when teaching medical students, for instance, how to have conversations with patients.
Question to the right.
Hi, Tony Bettinato, New Jersey. Thank you for this great presentation. I apologize if it's just my lack of knowledge on this area or if I missed something you said, but how do you know that the patients trusted you after you did all these things?
Great question, and actually very important to this topic. So there are many studies out there looking into patients rating the trust of their attendings after an encounter, or asking patients to comment on, okay, how did the provider give them trust? There are very few studies looking into, okay, what are those actual discrete behaviors that may enable trust with patients? And so in order to figure out which of these behaviors is most effective, first we need to know what those behaviors actually are. And so in my mind, this study is kind of that first step. Okay, now we have 24 discrete trust-building languages or behaviors that we can use. Now we can actually compare them and see, okay, are certain of these behaviors more effective or not in establishing trust with patients? And then we can teach those potentially more effective behaviors. But you're exactly right. I don't know that these behaviors established high or low levels of trust with patients. I do know that they're in line with several other models of entrustment, specifically in occupational trust building and in educational trust building, but that's the next step.
Great, thank you.
Question to the far right.
Tony Yang, Indiana. No disclosures, I think we're supposed to say too. Great study. Takes a lot of work, so I want to recognize that. These qualitative studies are really hard to do and take a ton of work, so congratulations on that. Along the lines of trying to suss this out a little bit more, did you guys do any kind of subgroup analysis around groups of people, surgeons, whether by specialty, level of training, experience, about whether they maybe exhibited more of these behaviors or less of these behaviors during an encounter?
No, good question. Originally, I was hoping we would have more trainees in our data set because I wanted to look and compare medical students to residents to fellows to see if we would have a progression, for instance, in the behaviors that are used. But unfortunately, we didn't quite have enough people for me to reach thematic saturation in each of these levels. One thing that I did note that I was interested in, sorry we didn't have time to present that today, is that with respect to attending behaviors, it tended to be the same subset of trust-building behaviors that every attending used, if that makes sense. So all of these behaviors are typically typically not expressed by the same surgeon, but often it was very similar behaviors for each patient care visit, likely because the patient care visits were similar, right? Counseling patients with low-risk thyroid cancer. But that's something that I would love to investigate further.
And along Dr. Benenato's question lines, you have a ready source of outcomes related to patient satisfaction scores that we get all the time, whether we like them or not, or agree with them or not. Do you have any teasers for us about if you've looked at it yet or not? I know it's a future project.
No, thank you. A future project. I haven't looked at it quite yet.
All right, thank you.
Thank you.
We have one last time, a little bit more time for one last question.
Thank you. Jacob Moellen from the University of Rochester with no conflicts other than my own ignorance on this subject. But I'm very curious to hear what you think about the relative importance of the individual building blocks or sort of menu options that you've outlined versus the alignment between these potential behaviors and the personality of the surgeon who's speaking with the patient. Because to me, it seems like what might be effective to for one person would feel so unnatural for someone else. And how do you begin to kind of suss that out when you're evaluating these encounters?
It's a wonderful question because I think about that a lot when I'm thinking about how am I teaching my medical students and residents. Because if I teach them what works for me, that might not be what works for them. And so when I think about these building blocks, I think of them more as I should teach these different tools of the trade so that way our future surgeons can find the ones that resonate with them, that work, because it's unlikely that all of these things are going to be things that work effectively for me or for you or for anyone in the audience, but a subset of them likely will. And then also I think it's important to recognize that my trust-building behaviors may not land with every patient that I interact with. The different patients may need a different tool. And so if I can at least have a passing knowledge or understanding of how to use tools I don't typically use, then if what I normally do isn't working, I can maybe dust off those other behaviors and use them in that visit to see if I can help establish better trust with those patients.
That's a lot. Thank you.
Yeah.
Thank you. Very nice.
Okay, our next paper from the University of Toronto, Factors Associated with Persistent or Recurrent Primary Hyperparathyroidism After Surgical Treatment, a population-based cohort study of 4,400 patients, presented by Dr. Florence Bernard.
Hi, everyone. My name is Paige McKinley. I am not Florence Bernard. And I'm from the University of Toronto, and I'm doing my PhD there. And I wanted to take the time to also thank the AES for hosting us today and allowing us to present our work. And we have no disclosures. So parathyroidectomy remains the only curative treatment option for primary hyperparathyroidism. And the AAES set an expected guideline outcome of 95 to 99% cure rates for sporadic cases. We do see in the literature that high-volume surgeons are meeting this threshold of 95%, but there's limited population-level data looking at biochemical cure and factors associated with biochemical cure. It's mostly limited to high-volume centers. So, the objective of our study is to identify population-level predictors of non-cure following parathyroidectomy in Ontario. So this was a retrospective cohort study conducted over a 4-year period, and we used the Institute of Clinical Evaluative Sciences, or ICES. And ICES captures province-wide data, and since Ontario is a universal healthcare system, this encompasses the whole population. And we included adult patients who underwent a parathyroidectomy for a biochemical diagnosis of primary hyperparathyroidism, and I'd like to emphasize that we used biochemical data as opposed to the diagnosis code on file. And we define this as elevated calcium levels of 10.4 or higher and non-suppressed PTH of 20.75 or higher. We excluded any patients who had less than 2 postoperative calcium measurements and if they underwent a reoperation or had secondary or tertiary disease. And we defined our biochemical cure as sustained normal calcemia within 1 year after surgery. And in order to assess our outcome, which was persistent or recurrent disease, we used a random intercept multivariable Poisson regression model. So of a cohort of around 30,000 patients who were diagnosed with primary hyperparathyroidism in Ontario, we had 5,136 patients undergo a parathyroidectomy, and this is reflective of quite a low surgical rate in Ontario of around 16%. So after applying our exclusion criteria, we had about 4,230 patients included in our sample population, of which 401 of these patients had recurrent or persistent disease. And this gave us a population-level cure rate of 90.5%. So now I'll just give a brief overview of the patient and surgical baseline characteristics of the cured versus the non-cured patients. We saw that cured patients were more likely to have a single adenoma as opposed to multi-gland disease. They were also more likely to have the use of intraoperative PTH and have their surgery performed by a high-volume surgeon, which we defined as greater than 40 cases performed per year. We also noticed that, 48.1% of all of the procedures were performed by a low-volume surgeon in this cohort. And now moving on to our primary analysis, which was predictors of non-cure following parathyroidectomy, we saw that older age as well as single parathyroid adenoma were both predictive of cure after parathyroidectomy. We actually saw the most notable trend in single adenoma, which reduced the rate of non-cure by greater than 50%. And then we saw some clinically significant or clinically relevant trends in higher surgeon and hospital volume, which we defined as greater than 40 cases per year. And we saw a similar trend in intraoperative PTH monitoring, where there was a trend towards reduction in failure of around 50%. And then lastly, we saw some risk factors, which were higher preoperative calcium levels, as well as lower hospital volume, and that was defined as less than 15 cases performed per year. Notably, only surgeons who were meeting the AES high volume benchmark were the surgeons that were actually achieving the cure rates of greater than 95%. So overall in this study, we saw that both disease biology as well as system level factors play into cure rates following a parathyroidectomy. And this was one of the largest population-based studies looking into biochemical follow-up. And at a province level in Ontario, we saw that our cure rates were lower than those typically reported by high-volume surgeons and also lower than the AES benchmark. So we have begun some further work looking into surgical approach in our healthcare system in order to improve these cure rates in Ontario. And with that, I'd like to thank the AES for the privilege of the podium. Thank you very much, and I'll take any questions.
Thank you very much, Paige, and my apologies for the name switch. I was a little slow on the bolding code here in the book. We'll take our first question right over here.
Hi, Sarah Altman from UT Southwestern, nothing to disclose. This is great work. Will you guys be using these data to go back to the government in support of being able to use IOPTH more uniformly?
Yes, we do plan on doing this. We have had a lot of discussion around the use of intraoperative PTH, and we see that there's really low use of intraoperative PTH in Ontario. And I think that's a really important discussion that we need to continue to have in Ontario and elsewhere. Thank you for your question.
Saray? Alan?
Super Stein, Cleveland. One little point in terms of data analysis, if you have a cutoff threshold for the diagnosis, you may be prejudicing your patients with higher or lower calciums in terms of just crossing that 10.4 threshold. And I guess one question is, do you have postoperative PTH to use the same criteria for cure as you did for diagnosis?
Yes, we did have the PTH data, but we didn't use this for our diagnosis or we did use it for the diagnosis of primary hyperparathyroidism. You used both the PTH and the elevated calcium levels.
And then my second question is, did you look at the intended initial operation? That is, was the initial operation intended as a focal exploration or intended as a bilateral exploration, and have that affect your outcomes?
Yeah, so unfortunately within ICES, we didn't have this data available, but I think it's a really important concept. And we have been looking into this with discussion in Ontario with other surgeons about what approach they're using. And we see that it's a common trend to actually be using a focused para without intraoperative PTH and not doing a bilateral exploration or multi-gland exploration.
I actually have a question, and forgive me if the data has already explained this, but you mentioned as protective factors single adenoma and the use of intraoperative PTH, but aren't those somewhat correlated with each other?
Yeah. So we saw that the intraoperative PTH wasn't clinically significant in this cohort, and I think that was because we just didn't have enough surgeons using intraoperative PTH, but we do see a similar trend in the single adenoma versus the intraoperative PTH. They follow the same trend for sure.
Thank you very much for this great paper.
Thank you.
Our next paper for presentation is Specialized Care for Medullary Thyroid Cancer, a SEER Medicare study of Medicare Advantage and fee-for-service beneficiaries. This will be presented by Dr. Landau from University of Pennsylvania.
Thank you very much. My name is Sarah Landau. I am a general surgery resident at the University of Pennsylvania, and I'd like to thank the AES for the privilege of the podium to share our work. Oh, it's going ahead without me. We have no relevant disclosures. There are two types of Medicare that older adults can choose from. The first is traditional fee-for-service Medicare, which is administered directly by the federal government. Alternatively, there are Medicare Advantage plans. These are administered by private insurance companies that contract with the federal government. These companies set local provider networks, and that determines which specialists beneficiaries can access. Recent work done in California has raised concerns that Medicare Advantage beneficiaries are less likely to utilize specialized cancer centers for GI and thoracic complex cancer surgery. Medullary thyroid cancer, which I will abbreviate as MTC, is a rare cancer with a heterogeneous disease course, and this can make long-term management challenging. Surgery is the only potentially curative treatment for patients with not distant metastases. And there's a very robust body of literature supporting a volume outcome relationship for thyroidectomy. Therefore, optimal treatment of MTC requires a combination of surgical expertise, specialized knowledge, and multidisciplinary care. The American College of Surgeons Commission on Cancer, or COC, accreditation can serve as a marker of such specialized cancer care. However, whether traditional Medicare and Medicare Advantage beneficiaries across the United States differentially utilize COC hospitals for surgical treatment is unknown. Therefore, we designed a study with two aims. Our primary aim was to describe COC hospital utilization by Medicare type, evaluating state as a potential effect modifier given the local regional nature of Medicare Advantage networks. Secondarily, we aim to compare MTC clinical outcomes by Medicare type. To do this, we conducted a retrospective cohort study of beneficiaries undergoing surgical treatment of MTC in the SEER Medicare database from 2018 to 2021. Our primary exposure was Medicare type, and our primary outcome was COC hospital utilization. Our secondary outcomes were clinical in nature and included postoperative complications, reoperations, and disease-specific survival. Our data were analyzed using the listed statistical methods. Our primary analytic cohort consisted of 381 patients who underwent surgical treatment of MTC. For clinical outcome ascertainment, we then used subset cohorts that were defined based on the duration of postoperative follow-up. In our primary cohort, approximately 60% of patients were enrolled in traditional Medicare, and the remainder 40% in Medicare Advantage. Demographic features were largely similar between the two groups, and as you can see in the table on this slide, there were no significant differences in cancer characteristics between Medicare groups. When looking at provider characteristics, we looked at surgeon and hospital volumes. Importantly, these volumes were defined as any partial or total thyroidectomy performed for any type of thyroid cancer in the SEER Medicare database. As you can see, there were no significant differences in annual average surgeon or hospital volume by Medicare type. However, COC hospitals had significantly higher surgeon and hospital thyroidectomy volumes compared to non-accredited hospitals. In our overall cohort, 81.4% of patients received surgical treatment for MTC at a COC hospital. And as you can see, there were no significant differences at the population level by Medicare type. However, when stratified by state, we did note state-level variation. Specifically, in California and New York, our two largest SEER states, we identified significant variation in Medicare Advantage beneficiaries were less likely to utilize COC hospitals compared to traditional Medicare beneficiaries. In this graph on the right, you can see the relative percentage of beneficiaries utilizing COC hospitals. And there's quite heterogeneous utilization across states. So for the states depicted in blue, Medicare Advantage beneficiaries were actually more likely to utilize COC hospitals, whereas in the states depicted in red, Medicare Advantage beneficiaries were less likely to utilize COC hospitals. This slide depicts our post-operative outcomes. As you can see, the rates of reoperation and MTC-related death were rare, and there were no statistically significant differences by Medicare type for any of the clinical outcomes. This study cannot be interpreted in light of several limitations. First, as with any administrative claims study, we are subject to misclassification of variables due to coding errors or differential billing practices. Second, SEER does not distinguish between the types of COC hospitals, and given that there are 5 levels of COC accreditation, it's possible that Medicare Advantage and traditional Medicare beneficiaries are utilizing different types of COC hospitals. And lastly, SEER Medicare does not provide specific clinical data, and our follow-up period was relatively short for this cohort, and this may have limited our ability to detect significant differences in clinical outcomes. In spite of these limitations, we found that MTC surgical treatment at COC hospitals is similar among Medicare Advantage and traditional Medicare beneficiaries at the population level. However, there is significant state-level variation in utilization. This suggests that it will be very important to account for local regional variation when studying thyroid cancer care delivery among Medicare Advantage beneficiaries. Further, this suggests that older adults with MTC should consider their local provider networks when choosing between Medicare plan types. And lastly, we hope that these findings will encourage specialized MTC clinical registries to consider Medicare type as a data element and to be cognizant of the types of hospitals contributing data to their registry to ensure that we capture the entire Medicare population. Thank you very much, and with that, I'll take any questions.
Thank you for a very nice presentation.
Sorry.
Question?
Sorry.
Yeah, go ahead.
Sam, Enuma, Rochester, no disclosures. Thank you so much for that talk. Have you guys looked at other cancers besides medullary? I was interested in you showed the state level variation across, I presume, all 50 states, but I guess my concern would be you only have about 500 people total in the whole cohort divided by 50 states across 3 different years. And obviously you're going to have some percentage differences, but I would imagine that across each individual state there's only a handful of patients. So I was wondering if you saw similar trends in a different kind of cancer where your sample size would be much larger.
Yeah, thank you for that question. We did. We actually looked at differentiated thyroid cancer, which is a larger population, as well as colorectal cancer, which is an even larger population. And while the individual states differ, the fact that there is state-level variation but not overall population-level variation is a consistent theme that we're noticing, which I think just reinforces the fact that these local regional networks are really important.
Wonderful. Great work.
Next question on the right.
Tony Yang, Indiana, no disclosures. Great study on an important problem related to Medicare Advantage. I was interested in your choice of using COC. I'm wholly a believer in the COC and its benefits for cancer care, but there's no COC guidelines specifically related to medullary thyroid cancer or thyroid cancer in general. Did you look at any other cancer certifications possibly or other programs like that, such as, say, NCCN, where we have medullary thyroid cancer guidelines, or NCI designation, or other programs like that as well?
Yeah, thank you. We did try to look at NCI designation, but there's a lot of differential missingness between Medicare Advantage and fee-for-service beneficiaries, so it actually really biases the results. We chose COC because we had 100% capture in SEER, and so we felt like it was a reliable outcome to use to be able to study it on a large scale. But I agree with you that I think especially for medullary cancer, which is so nuanced, it would be important to look at other levels of specialization.
Thanks.
Thank you very much for a great presentation.
So I think that concludes this scientific session. Thank you guys very much. Thank you to all the presenters.